welcome to any new people that have joined us. I'll just say a little bit about the group, just to give a bit of background and our very sort of simple rules for the session. So it's a national group. It's welcome to anybody with an interest in personalised cancer care in primary care, and particularly those kind of with an interest of kind of living with and beyond cancer, and improving patient experience. And we meet quarterly. Open, as I said, open to anybody who's got an interest in that nationally. And so do please invite colleagues or people that you think would be interested in joining. And we do try and keep things fairly informal. So we do want questions and we do want some discussion. I just urge you just to pop your hands up or use the chat. And I believe that there's some points in the presentation today where you're going to invite some discussion. So I'm sure our speakers will kind of explain that as they go. And just to say, we're recording, so there's there'll be a copy of it on our website or our webpage. So if you don't want to be on camera, then obviously just keep your camera off. So, with no further ado, I'm going to hand over to both our speakers for the day. Just to say, right at the end, I'm going to have maybe just 5 minutes just to talk about 2026. I've got a survey that I want people to complete. If people do have to jump off before that, I'll be sharing the survey anyway, so don't worry. But I'm interested in kind of topics for 2026 and your sort of thoughts about what's gone well in 2025. So always wanting to kind of improve and develop the group. But anyway, I'm going to hand over and introduce our two speakers. So we've got Eila Watson, who's Professor of Supportive Cancer Care, and Dr. Lucy McGeagh. So I hope I pronounced that right. Who's Senior Research Fellow at both at Oxford Brookes University. So I'm going to hand over. I'm going to unshare my slides now if you want me to. If you want to share yours. Yep. Okay, bear with me.
So should I try and share now?
Yeah, hang on, let me just unshare mine, sorry. Have mine disappeared or they still?
Yours have gone, Sandra.
Yours have gone.
Okay, go for it then.
Okay.
Looking optimistic, Lucy.
It is. Can we get it into PowerPoint mode?
Slide. Yeah.
That's
it.
Can everybody see that?
I can see it, Lucy, so I think it's okay.
Okay.
Yes, so I'll start off. Hi, everyone. A big thank you to Sandra for giving us the opportunity to come and chat to you all today. We're really pleased to be here. And Lucy and I are doing a bit of a double act. We're part of the SWEET research team. As Sandra said, we're both based at Oxford Brookes University, where I'm Professor of Supportive Cancer Care and Lucy's Senior Researcher on the SWEET programme. And our SWEET programme is all about supporting women with adherence to endocrine therapy following breast cancer. And if we move on to the next slide, Lucy, please. We're just representing really a big team. Myself and my colleague Linda Sharp, who's at Newcastle University, are leading this programme of research. And you can see we've got a lot of collaborators around the country and all over the place. We're a multidisciplinary team with surgeons, oncologists, representatives from primary care, health psychology, and so on as part of the team. So I just wanted to acknowledge everybody before we go on. And then on the next slide, what we're hoping to cover with you today is just a bit of a background to our SWEET programme, and then tell you about the support package we've developed for women around endocrine therapy, a bit about the randomised controlled trial that's currently underway. And then what we really want to focus on is what happens beyond the trial and implementation of this intervention or parts of this intervention. And obviously today we're particularly interested in the role of primary care. So we really do want this to be interactive, and as Sandra says, we have got discussion questions that we'd like to just chat with you about. So without further ado, I think for this audience, really, I don't need to give you much of a background. You all know that we have more than 55,000 people diagnosed with breast cancer every year. And the vast majority of these women have estrogen receptor positive breast cancer. And the vast majority of those women are then prescribed adjuvant endocrine therapy to take, either tamoxifen or an aromatase inhibitor. And that's usually for 5, maybe more commonly 7 up to 10 years nowadays. But on the next slide, the issue is, you may not be as familiar with this, many women don't take their hormone therapy as recommended. So there's good evidence now that about 20% of women have stopped by the time you get to 2 years, and about half of women have stopped by the time they get to 5 years. And in terms of, so that's stopping altogether. And then there's a sort of higher, there's another proportion of women who don't take the medicine as prescribed. So they take less doses, or they skip doses, or they stop and start. And as you'll be aware, there is good evidence that if you do adhere to this medication, it really does reduce your risk of recurrence and of dying from breast cancer. So there's strong evidence. So we were really keen to think about what we could do, support women to stick with endocrine therapy when it's prescribed. And we've done quite a lot of background work in this area before we got the SWEET programme funded. So the SWEET programme's been funded by NIHR. It's actually been a 7-year programme of research. So it's been a big investment. And what we've sought to do is to develop and then to trial what we would call an evidence-based, theoretically informed and a patient-centred intervention. And the whole idea is to try and help women to take the endocrine therapy as prescribed and stick with it, and thereby to prevent and reduce poor adherence. But we also want to try and improve cancer-related quality of life. And we're hoping that through this, in the longer term, we'll be able to reduce breast cancer recurrences. So our programme started just bang at the same time COVID started. So that was interesting. So the first phase was developing the intervention. And that did take us a couple of years. And we're going to tell you a little bit more about that. We then went on to conduct a feasibility study to see, is this feasible? Can we deliver it in the NHS? Is it acceptable to women and healthcare professionals? And we're now in the phase of conducting our big randomised control trial. And then what we're planning for now is implementation once the trial's finished, and that will be in 2028. But everything takes so long to get organised. We're trying to think about things ahead of the game, if you like. So on the next slide, just to tell you about our intervention development phase, we've called it HT&Me, our support package. And there's lots of literature, as you'll be aware, around intervention development, healthcare intervention development, and complex interventions, of which this is a complex intervention. And there's these 3 pillars that get referred to. The first is you have to really have a good understanding of the issue or the behaviour it is that you're trying to address. Your intervention needs to have a theoretical basis, some sort of theory that increases the chances of it working. And you need to have good stakeholder involvement. And the final thing for us, of course, was to have an eye on, this. We want something that's going to work within an NHS setting. So in terms of understanding the issue, we've done a lot of work interviewing women, healthcare professionals about taking hormone therapy. And just to summarise it all, ourselves and others have done quite a lot. So there's a lot of literature about what the determinants of adherence are, and we've sort of culminated that with a systematic review of reviews. So that just tells you how much evidence is out there. So we know what the challenges are for women around side effects, it being a reminder of breast cancer, forgetting, all these sorts of issues, relationship with healthcare professional. So we were armed with good evidence. And then our theory is on the next slide. We use this theory called the perceptions and practicalities approach. It's PAPA, it's known as. It's referenced in NICE guidance on adherence. And really, it's a very simple theory, and it's just saying that the best way to prevent poor adherence, if you build at the outset a very sort of common sense rationale for why it's important to take the hormone therapy, and you get a good understanding, or you convey to the people who you're trying to support with adherence about the necessity, so they understand why it's important to take it, and that you understand their concerns and address their concerns and support them with their concerns. And in that way, you will then increase adherence. So that was our underlying theory. And in terms of working with stakeholders, we did a huge amount of this. We had a we have and we still have a great patient advisory group. That's a diverse group of 11 women who have had breast cancer and experience of endocrine therapy. And in the intervention development phase of our work, we met with these women every sort of 1 to 2 months, and they really were central to shaping our intervention. And beyond the advisory group, we had another group of 28 women, and Lucy kept in touch with these women online. They also had experience of breast cancer and hormone therapy, and they kind of served as a panel for us, and they were really great in sending in their hints and tips for managing side effects, etc. And that all got incorporated into our intervention. And then we were guided also by a clinical reference group with oncologists, surgeons, clinical nurse specialists, pharmacists, GPs. Sandra was part of our clinical reference group, which is how we're here today, clinical psychologists, etc., etc. So we consulted widely with all of these people. And then on our next slide, we came up with some sort of guiding principles for the support package. So we wanted to support them to be able to take their hormone therapy, but it was important to us that we recognised it is an informed choice at the end of the day. And if someone armed with all the information decides it's not for them, then that's absolutely fine. But what we wanted to do, from speaking to our women in the PAG, we wanted them to see hormone therapy as an integral part of their treatment, and something they could that's the most important thing they can do to look after themselves after the end of their hospital-based treatment, if you like. It was interesting talking to the patients because they told us they didn't see hormone therapy in the same way as they did the radiotherapy or the chemotherapy, which you traditionally think of as your cancer treatments, but arguably just as important. We also thought it was really important to facilitate communication for women with breast cancer with their family and friends, and also with healthcare professionals. And as I've said a number of times, we wanted it to be scalable and implementable. And I think on the next slide just sort of summarises our content. So we wanted to provide information and advice. We wanted to support women to develop a sort of routine for taking their hormone therapy. We wanted our intervention to help uncover what was worrying women and concerning women, and then provide tailored support to meet those needs and actively address any concerns. And Lucy, I'm going to hand over to Lucy now, who's going to take you through the different elements of the support package that we have developed. So over to you, Lucy.
Thank you, Eila. Can you still hear me okay?
Yeah.
Yeah, perfect. Thank you. Okay, so this is what our support package looks like. So it's broken down into 4 core components. So the woman will be prescribed hormone therapy, and ideally she would experience this support package within the first few months since she's been prescribed hormone therapy. And the first thing that happens is she is invited to view an animation. So this is a 6-minute cartoon video, which builds upon the common sense rationale. So the what, the how, and the why of hormone therapy, because we know that often women may be given a prescription, told to take this medication, but it's not really explained why and what it does and why it's important to take it every day. So that's what the animation focuses on. They then have a tailored consultation. It says with a nurse here, but a tailored consultation with a healthcare professional that's been trained to deliver this intervention. So this is approximately half an hour consultation, and the purpose is to strengthen the necessity beliefs. So this is all sort of focused around the PAPA theory, to strengthen those necessity beliefs and address any initial concerns about taking hormone therapy, and also to introduce them to the HTME web app. So the HTME web app, which is the third component, is an interactive website that can be tailored to the individual, that can be accessed on a mobile phone, a desktop, a laptop, or a tablet. So it's got a lot of personalized information, it's got lots of coping strategies, it's based upon behavior change theory, and there's a lot of support in it. And I will give a demo, hopefully, in a moment of what the HTME website looks like. So the second part of this component of consultation, so 3 months later, the lady would have another consultation with that same nurse or healthcare professional. That's to check in, to reinforce the necessity of taking the hormone therapy and address any emerging concerns or problems that they have, either with taking the hormone therapy or with accessing and using the website. And then alongside this, they would also receive regular nudge messages. So these are motivational reminders sent via text or email as per her preference. And the purpose of them is to both motivate them to and remind them to take that hormone therapy every day, and also to nudge them back to the web app for additional support. So I'm now going to try, if I stop sharing for a moment. Okay, I'm going to try and give you a little demonstration of what the website looks like. Just bear with me a moment. Okay, can you see the HTME website?
Yeah, we're on the login page, Lucy.
Perfect. Yeah. Okay, so that's important to say that every person who has access to this would have a personalized individual login, so that they are able to put in any information and it's personal to them, and it's not going to be viewed by anybody else. So hopefully women can feel that this is sort of their toolkit and their support. So this is what our homepage looks like, and you can see we like to describe it as you've got your 4 information sharing purple bits, and then the 3 yellow interactive aspects down the right hand side. So I'm just going to quickly go through some of these sections just to give you a feel of what the actual website looks like. So the first section is taking hormone therapy, and in this section is the animation that I mentioned previously. So the women are able to look at this anytime they like. So they're invited to view it before they start having access to the website, but they're able to watch it as often as they like. And from some of the feedback we've got so far, women quite like to show this to their children or their partner, family members, to help explain a little bit more about their hormone therapy. So I am going to stop sharing again. I'm sorry to jump around so much, but hopefully I can. Okay, so let's just try and share this. Okay, hopefully you're able to see the animation now.
Let's see if it works.
Let's see if it works. Sorry, one more time. It looks like I can't share the sound, Sandra. Do you know if that's...
When you share your screen, there's a little thing at the top that says share your sounds.
It's saying it's not allowing me to do that for some reason.
I don't know them.
Okay.
Don't worry, Lucy.
Well, I'll show you it anyway without the sound, because it does have subtitles on it, and I think it's really important to just give you all a sort of taster of what the video looks like. Gotta love the technology.
Are you hoping it's starting partway through, Lucy?
Okay, so it has a beautiful narrative voiceover on there, and unfortunately you couldn't hear it. I could hear it then. But you can see that it really explains in lay language sort of what hormone therapy is, actually how it works, and also that you may experience side effects, but there is something that you can do about it and that you should speak to your health professional. So this is the taking hormone therapy page. You can see you've got a Q&A section, which is really useful. There's lots of questions that we know through speaking to clinicians and through speaking to women are very commonly concerns that they may have. There's a section where you can make a plan. So for example, I plan to take my hormone therapy every morning when I brush my teeth, and then they will get an email to say, how's it going? Did you manage to succeed with that plan? So that's the taking hormone therapy section. And we know that one of the main reasons that women tend to stop taking their hormone therapy can be side effects. So we've got a very detailed side effects information giving section. As you can see here, there are quite a few of the most common side effects listed. And then within each section, we go into quite a lot of detail about different ways that women can manage their hot flushes or their night sweats. And what's really nice is it's a balance between the evidence of what's been proven to help and support women, but also the community of interest group, the panel that we spoke to earlier, and our patient advisory group suggested a lot of hints and tips to us as well. And so we've included those, often in the woman's words, which really sort of adds to the feeling that those who are struggling are not alone. There's two other sections in the information giving aspect of the website. So we have the healthy living, healthy mind, and the help and support. But I just want to quickly talk about these two sections. So we've got my personal support, which is essentially a quiz where we can tailor this website to the individual. So by clicking on this button and answering a few questions, I can just show you. So taking my hormone therapy is very important to me. I disagree, actually. I don't think it's that important. So I'll click this, and I have concerns. Some, and taking my hormone therapy is difficult to me. So saying that my hormone therapy is not important to me triggers a few more questions, which I will answer. And this is a way, particularly when a woman first uses this website and there's so much information and it can be quite overwhelming. And this is a really lovely way to guide them to the aspects based upon the PAPA theory that would be most useful for them. So for example, this provides tailored information about why they need to take their hormone therapy. And then if they click on that link, it will take them to the relevant section. So it's a really nice way of guiding the woman around the website and tailoring it to her personal needs. And then the other section, which is really unique to this support package, is a hormone therapy diary. So the first thing that a woman can do is set a daily text or email reminder to take her hormone therapy, and also set up a monthly prescription ordering and collection reminder, which we have had feedback has been, for those who use it, is really, really useful. And the other thing that a lady can do is log her side effects. So this is a calendar. You can see here I've logged some different side effects, mood change, fatigue, and I've also logged the severity and the impact. So you can go into any given day, tick to say whether you've taken your hormone therapy that day. You can tick about which side effects you've experienced, how severe they were. And then you can also add comments. So for example, I had mood change on the 5th and I didn't go for a walk this morning. Now that may not be relevant, but this gives the woman a chance to try and track her side effects and see whether anything she's doing is making them better or worse, which both gives her control and can also try and, reduce the impact of those side effects. And then what they can do is print this out on a graph, and you can take this to your GP, to your breast care team, both to say, look, these are really impacting my day-to-day life. Now, this isn't beautiful because the data is not real life, so it's a little bit messy, but you can see, you can actually log how severe different side effects have been. And we know when we first spoke to women when we were developing this, that sometimes they felt going to a doctor, an oncologist, a GP who they knew are really busy and saying, oh, actually, I'm having some night sweats and they're really impacting me. But when they got to that health professional, they didn't always feel listened to, or the impact wasn't heard. And by taking this graph along to actually show the healthcare professional, look, it is impacting my day, really allows women to take control of these side effects. It also allows them to monitor whether they are going up or going down, because sometimes in the moment we're not always that good at being sort of aware of whether things are changing in a positive or negative way. So it really gives the woman a chance to sort of take control of her side effects. So I'll go back to sharing the slides now, but that just gives you a sort of oversight of what the HTME website looks like. As you can hopefully see, it's really interactive. It's developed very much with women who have experience of this, and with healthcare professionals who have experience in supporting women. So I'm just going to skip through the next few slides, because these were the backup if my link didn't work, which it did, which is great. Okay, so this is a really important thing to highlight. We currently have two models of delivery for the intervention. So we have our site-led model, where for the purpose of the trial, but in practice it would work as well, those who are associated with the breast care team are trained to deliver the intervention. So that could be a nurse or other healthcare professional. And then the patient would have their first consultation, ideally face-to-face, and their second consultation would be on the phone. The other model we have is the Breast Cancer Now model. So I'm sure you're all aware of the charity Breast Cancer Now. They have, one of the elements they do is they employ nurses who run a helpline. And we've trained 3 of those nurses to deliver the HTME intervention remotely. So for the purposes of the trial, which Eila will talk about in a moment, participants are recruited from the site, or in practice, they would be from a particular hospital, but then that intervention delivery is provided remotely via video consultation by a Breast Cancer Now nurse, which takes the sort of load away from the breast care teams where that's needed. So just to really briefly touch on the training, obviously, for the purpose of trialling this, we have trained, I believe, over 145 different healthcare professionals across the UK to deliver this intervention. So we needed quite a robust training program. And obviously those healthcare professionals, you know, they are not all breast care nurses or people with experience of hormone therapy. So we developed a training package which consisted of a 1-hour Zoom meeting training session with myself and another colleague, where we met in, say, small groups of sort of 2 or 3 healthcare professionals. We went through a number of slides and talked through different aspects. So thinking about hormone therapy, talking about the theory, talking about what the consultations involved. And then they had to do 7 to 8 hours of online training covering these 5 modules. So looking at the suite study and thinking a little bit more about hormone therapy, going into the HTME website in detail, because what we're seeing is those who are delivering the consultation, who are really familiar with the website, are able to sort of engage with the women more and get them sort of more comfortable with using it themselves. We've then got a module on the theory and introducing the consultation guide. So what happens in that consultation? We've got some typical consultations. And then for the purposes of the trial, we've got the study paperwork and logistics. And then we've got a live Q&A session if they want, once they've done the training, which only a few members of healthcare professionals took that up. And this is just some slides from what the training looked like, but you can see it really went into detail, and that was a 1-hour training session initially. So Eila, should I hand back over to you to talk a little bit about the trial?
So I'll just tell you about the randomized control trial that's underway now. So obviously we're targeting women who've been recently diagnosed with breast cancer, who've completed their they've completed their surgery, and if relevant, their chemotherapy, and have been prescribed endocrine therapy within the past 3 months. So the next slide just summarises the trial design. So it's a multi-centre unblinded trial, and we're comparing our HTME intervention plus usual care versus usual care alone. And our primary outcomes of interest, you won't be surprised to hear, are adherence, which we're measuring via self-report on questionnaires and also through prescription encashment records. We're also looking at quality of life. And our secondary outcomes are breast cancer related quality of life and cost effectiveness. So once women are in the trial and randomized, they do a questionnaire at baseline, and then at 6 months, 12 months, and at 18 months. And we've also got a parallel process evaluation, which we'll say a little bit about. And on the next slide, I think just summarises where we're at. So the trial is open in 66 hospitals around the UK. We've managed to get it open in all 4 countries, which we're really pleased about. And we've got 40 sites using the sort of site-led model and 26 using the Breast Cancer Now model. So we should be able to draw some conclusions about both ways of doing this. So we've got over 1,600 women in the trial recruited. So we've reached our target. In fact, we're 15% over the target. So we're really pleased about that. And we're in the follow-up phase. So the final follow-up is due the end of March 2027. So that will be everybody had 18 months. And we would expect our trial results to be out at the beginning of 2028. So that's where we are. And Lucy, you're just going to say a quick word or two about the process evaluation.
Absolutely. So because this is a very large trial and we're really interested in how it's worked, what's worked well, where there's areas for improvement, and also thinking about implementation within that process evaluation as well. So we are currently conducting interviews with 60 participants who've taken part in the study. So 30 from the intervention arm, 30 from the usual care arm. I've interviewed 31 so far, and the interviews explore experiences of being in the study. Also, for those who are in the intervention arm, what it's like to use HT&Me, how they found the nudges, how they found the different aspects, and as well as just general experiences of hormone therapy for all of the women involved. And then we're also interviewing healthcare professionals who've been involved actively in the study. So the aim is to interview 25 of those, and I think I'm up to 22 actually so far. And this is to explore sort of the context of delivery this. So what was it like to deliver, but also potential barriers and facilitators for implementation beyond the trial. Just briefly, just to show you sort of how people are finding this so far. So what we found is that in the intervention arm, most of the women are highly adherent, which is obviously something that is not that surprising in a research study. Those who take part in research are more likely to potentially be more adherent. But they found that the consultations really are valuable. They really like the animation. Somebody said it reminded me why I'm taking it and it motivates me to continue. Others have shared it with their family and they watch it often. Some of them love the website and they dip in and out. It seems that those who use it really, really use it. They love the reminders. They like their daily text. They like to log their side effects. Those who aren't using it often caveat to say, but I understand how other people would use it and those who may be struggling would benefit from it. And then in the usual care arm, generally the feeling is that not much information is given about hormone therapy and they often want more support. They really would value to have the intervention. And they would have really found it helpful if they'd been in the intervention arm, in their opinion. There were some examples where myself and my colleague who conducted the interviews felt that it would have really benefited that individual. So some of them talked about, I spoke to a lady who spoke about the sexual side effects she was experiencing and she hadn't wanted to talk to anyone about it and she just wished that there was something, information that she could access about that, which obviously HT&Me does provide. Some women said that they just wanted to know they weren't the only ones, and we've got a lot of quotes and experiences of other women on the HT&Me website, which provides that sort of reassurance that they're not alone. We also spoke to 2 ladies who both stopped taking their hormone therapy and said that actually if they'd have had more support, they may have carried on. And then these are just a few quotes. So talking about the video, somebody said, I wish I watched that when I'd started taking tamoxifen because I don't feel that you're told that much. You're not given much information, and that's a powerful video. Another lady said she liked the inclusivity of it. I love that the imagery, the inclusivity is important. It was brilliant. And it explained about estrogen receptors, and that was superb. And another, talking about other people, said, I really like the quotes. they look like they're written word for word, and some of them are so real and so raw, and I like that because it's not just someone paying lip service to the website to make it look like real people have commented. You know, it really was real people. So that's really positive to know that so far it's being received well. Eila, web analytics.
Yeah, I was just going to, very briefly, we have some preliminary analysis of website usage. And what we can conclude so far is that 77% of women in the intervention arm have access to the website, which is good. And in their first month of access, what we can see is that participants tend to be active on the site for two-ish plus days. And then some participants are coming back to the website nearly every day over the first 6 months. And we think that's probably using the diary. But most of them who have gone onto it seem to be returning at least once a month. And we're wondering, is this driven by the email text nudges we're sending them, driving traffic to the site? But these are all things for us to look at. In terms of which sections of the website are most popular, you can just see there that dealing with side effects and the diary and healthy living are sort of amongst the most popular bits. And I think if you click again, Lucy, I think, so within the side effects section, people are most often clicking on bits around joint pain, hot flashes, fatigue, perhaps as you would expect. So if we just move on. So now we really want to focus the discussion on planning for implementation. So in an ideal world, HT&ME would be adopted by the NHS and rolled out across the UK. But of course, first, before we've got any chance of that happening, we need evidence of effectiveness and cost effectiveness. So we do have to wait for the trial findings. But nonetheless, that aside, we are encouraged by just women's responses to the website and the animation, etc., etc. So we have been encouraged to sort of really think about rollout and make sure we don't lose momentum at the end of the trial. So what we're doing now is sort of trying to explore various options and routes simultaneously. So we're trying to engage with implementation experts and key stakeholders, which is including yourselves. And we're in discussion with various organisations who might be able to, if you like, take on the web app, maintain it and make it available to women. We're speaking to Breast Cancer Now about that. There's other potential charities. We would like to make our training package an adapted version of it, not as long as it is currently, probably for nurses and healthcare professionals available. We've put a lot of effort into it, so we wouldn't want to see it going to waste because we feel it could be useful. And we're also exploring how we might be able to incorporate a link to HT&ME into other websites that are sort of regularly used by healthcare professionals, either in primary care or in secondary care or in both. So I think on the next slide are just some questions we'd be interested to have a chat with you about. You know, we're interested in what your experiences are about the current role of primary care in supporting women prescribed endocrine therapy, whether or not you think primary care could or should play a bigger role, and how would that happen? Who would it be? Would it be the GP or the nurse or pharmacist perhaps? Or I know in some areas, we're having an interesting conversation with Sandra last time that some commissioning areas have a sort of primary care based oncology nurse, which I think is an interesting model. We're interested in your thoughts. Could you envisage primary care delivering the HT&ME intervention or elements of it? What sort of training platforms do you use that we might be able to tap into? And would you make use of the animation or the web app? And what would be the best way to make this available to women in primary care? I think we have had, Lucy, were you involved in in meeting with was it patient.info, the website?
Yes, yeah.
Yeah. Do you want to say a little bit about that?
Yeah, absolutely. So we met with somebody from patient.info who essentially said that there's quite a lot of opportunity there for us to incorporate aspects of HT&ME or to direct traffic, because obviously if this is a website where professionals are going, it would be a really good way to engage with GPs or with others in primary care. But again, it would be interesting to know, are you aware of, do you use patient.info? Is that something that you think would work? But yeah, it's an option for us to engage with them to sort of see how we can embed aspects of HT&Me and direct the traffic and the support pathways through patient.info. Do you want me to stop sharing so we can?
I think so. I think so. We'd really, or maybe we leave the questions up. I don't know. It would just be lovely to get any thoughts or feedback from anybody out there.
Yeah, I think it's helpful to keep the questions up because it might just help focus the discussion,
Yeah.
mightn't it? But I just want to draw attention to a couple of things in the chat because I know I'm going to forget otherwise. So one person, Lisa's asked if there's a link to the animation so people can watch it afterwards, given that we weren't able to hear it. Is there a way that you can share that, or is that something within the website that's not available
Yeah,
to
we
the
could
public?
probably send that around, Lucy, I think, couldn't we?
I think the only issue we have to be mindful of is contamination, because obviously only our intervention women have seen this. So I think I'm sure there's a way we can do something with it. We can have a chat as a team and work out.
Yeah,
how
I mean,
I
think we could share it. Yeah, we could share it, but not for onward sharing at this point until the trial's finished, but so that people could get a flavour for it. Yeah, we can get back to you on that.
Yeah, definitely.
Sure. Okay. There was someone who's saying, can you come and speak to their Cancer Alliance? I might ask you to pick that up with Sandra Smith afterwards. There's a question about the use of AQRX. I don't know if you're familiar with AQRX, Eila and Lucy. So
somebody has mentioned that. Can you remind us what it is?
Yeah, so it's the messaging service that we use in lots of primary care areas. So basically that enables us to send links to websites or a self-generated text message or a questionnaire to patients. So there's quite a lot of functionality within it. So is that something
that would be
useful?
good? That would potentially be very useful. Yeah.
Okay. And there's some more kind of in-depth questions in the chat. So I might ask those people if they don't mind, if they're able to, if they can come on camera and just ask. So somebody's a cancer care coordinator doing cancer care reviews. Do you want to come in, Rebecca? Are you able to speak? Rather than me reading out your comment.
Yeah. I do cancer care reviews in primary care, and I think the training that you described would be so useful from my point of view of my role, because I speak to a lot of ladies who are having issues with side effects. And yeah, I think in the future it would be really beneficial to have this whole program. I can see how it could work in primary care. My role isn't a clinical role, although I have a clinical background, so I kind of work quite closely with the GP, so all the practice nurses could be involved. And I think you mentioned a kind of conversation with the nurse at 3 months, but yeah, it would be amazing, I think, from the role that I do.
Yeah, I think the cancer care review is something we wondered about. I was under the impression that wasn't necessarily continuing everywhere. Is it still part of the QOF? I thought that had been changed, or am I out of touch?
Yeah, it's not part of QOF. Where I'm working, we're continuing them because it's good practice. But yeah, it's not part of QOF.
That's really good to hear.
Yeah. Because that would be an ideal place to situate something like this. So we're very interested in primary care as a setting for this sort of intervention. In our initial idea, before Sweet started, we thought about in pharmacies or in primary care, but it was too hard to get the trial up and running. So we went with a secondary care based trial, but we've always been very interested in primary care and how we could get this out there. So cancer care reviews was one potential idea.
Okay.
Yeah, if they're continuing in different places, then yeah, it could be.
Yeah.
I think the state of play is it's very variable, I think. So we did a recent survey of the National Cancer Care Coordinator Community of Practice, and lots of them, although they were continuing doing their kind of part of the cancer care review, they reported that that GPs, for example, had sort of ceased activity in lots of cases. So I think it is very variable, and obviously depends on who's doing which component as to how much that impacts the CCR. So I think it's something we need to collect more data on and have a better understanding of how that's impacting patients. But I think that the general trend is kind of downwards in terms of it not happening as often as always consistently for patients. I'm going to bring in Lena, who's got her hand up.
Yes, can you hear me?
Yeah,
Hopefully
we can
not
hear
too
you.
much of an echo. Thank you very much. That was really, really interesting. So I work for the SWAC Cancer Alliance, which is in Somerset, Wiltshire, Avon and Gloucester. And before that, I was a practice lead nurse and did a lot of the cancer care reviews before they sort of dropped off from the QOF. But I've been sort of hearing about the 10-year health plan that obviously has been published already, but also the upcoming 10-year cancer plan plus the workforce plan. I think this would sit perfectly in a sort of personalised care and support more in a neighbourhood and primary care and community care. It would sort of fit in very well with the government plans and NHS plans to move the care towards more where the people are, like the sort of, the hope courses and other sort of supportive things that people would then also meet other people that are going through the same thing within their community, and sort of and also if it would be delivered perhaps sort of online as well, or like, I don't know, in the earlier slides you said there is sort of online option as well, sort of that would support that sort of digital and sort of going from analog and face-to-face appointments to perhaps open the sort of for the wider audience as well. I think it's great. Looks amazing, the website and the platform, and really good because it's sort of interactive, lets the ownership for the patient as well to really record side effects and when they feel well or when they feel more unwell. So really, really interested to hear more and take this to my Cancer Alliance as well.
Wonderful.
Thank you.
Thank you.
That'd be great. Yeah, I think we were unsure how it would go to being delivered remotely, but it seems to have worked really well with the Breast Cancer Now nurses. There haven't been many hitches, and I think because we put so much effort into developing the website, it's really is easy for people to use. It's got buttons that say back and forward and click here. It's not that
user
hard.
friendly.
Yeah, it's quite user friendly. So yeah,
and I think sorry, Eila.
No, carry on, Lucy.
Just to say as well, with the remote element, and it's really positive to hear you say that, because as Eila said, we weren't sure about the remote, but in some of the interviews that I've conducted with women on the Breast Cancer Now model, they preferred having I know, and it's different with primary care because of parking, maybe less of an issue, but things such as driving to your hospital, going back to where you had that initial diagnosis, people don't always want to do that. Whereas if you're comfortable to have a Zoom chat or a Teams chat, then the remote model really works, and it possibly is more realistic. So if that would work in some locations alongside maybe doing it in physical practice in other primary care settings, I think that's really positive to hear. So thank you.
There's a few more comments in the chat. So Heather says you could put links or QR codes into treatment summaries for patients. They can revisit animations or web app. And obviously the treatment summaries are sent to GPs and primary care colleagues. So that could be a good way of signposting. Did you want to add anything to that, Heather? Or have I summarised your point?
No, I think you summarised that nicely. Thank you.
Then Pip suggested around the role of clinical pharmacists and sort of medication reviews and where this might fit in. Do you want to say something about that, Pip?
Just that a lot of our contacts with patients now regarding medication and concordance and reviews are done by med managers and the clinical pharmacists that are based in the GP surgeries now. So a lot of times we don't actually have that much contact with the patients when we do med reviews as clinicians. And excuse me, I think that them being aware of the HTME website would be really good too.
Okay.
So I think from our perspective, what we'd love to do is take forward some sort of pilot work in primary care around SWEET, and we have the opportunity to apply for sort of bits of funding that add on to this program. So we would be really interested in doing that, and we'd love to get a little group together with an interest in this area to help us shape something. So I don't know if anybody's interested, either contact myself and Lucy directly. I think you've got our emails on the thing, or perhaps through Sandra, or perhaps we could email out through you, Sandra. I don't know what's the best way. I'm just conscious of time. The hour has disappeared quickly.
Yeah. If it's okay, I'll share the slides, I'll PDF and share them, and obviously I'll include your email addresses. But obviously the slides will go to a bigger group than people who are here today, so it might be good just to write a paragraph or something of what you're looking for, and then we can share it with the bigger
That
group.
would be really helpful, Sandra.
Yeah. Okay.
And we've also got another study that we're hoping to get off the ground, looking at women around the 5-year point, which Lucy's going to be leading. So what happens at at that 5 years in terms of deciding whether to stay on extended hormone therapy or not, which is another area that's can be challenging for women. So yeah, so there's lots of things to chat about. So it would be great to keep the conversations going.
Yeah, and that's quite a lot of interest in the chat. So please, yeah, do that, and I'm sure we can keep the conversations going. I think the biggest challenge, and I think what's really unclear at the moment is what funding is going to be available in primary care to support cancer care, and how we can kind of harness the kind of energies within the 10-year health plan around integrated neighbourhood teams, etc. How we can make sure that cancer is a part of that conversation and story. And I think that's probably going to vary by geography, and there will be variation across the country. So it makes rolling out anything nationally really difficult, I think.
Really difficult, yeah. We might have to try rolling out in 1 or 2 sort of areas and see how it goes. Yeah.
So any final questions or comments for Eila and for Lucy? No. Okay. Well, thank you. I think everyone's really enjoyed that presentation and inspired by the kind of thoughts around how we support this group of patients better. And these are definitely patients that we're seeing in primary care with challenges of side effects. So I think it is really important that we're involved in the conversation about the long-term care.
So positive, I think, for us to hear, because we've developed something, and the idea that it will be well received is wonderful, I think.
Yeah, and thanks so much, Sandra, for the opportunity to come and present. And if anybody else, if it would be of help for us to present at any other meetings, we're more than happy to do that. We're keen to get it out there.
Cancer Alliances, just get in touch.
Well, okay, thank you.
Thank you.
Thanks, everyone.
Thanks both our speakers then, and we'll be in touch in relation to connecting people up. I'm just going to share my last slide because I've got a questionnaire. Muted myself. I've got a questionnaire that I'd like people to complete if they can. I will share it as well, but if this will let me move my slides on. There's an awful lot of slides. But while I'm doing that, just to say we haven't yet got dates for 2026 meetings, but I was kind of waiting for the results of this survey before we set some dates. So if hopefully you can see this, I haven't gone into. My PowerPoint's not quite plain ball, but you can scan it. Also, I'll send the link out as well, and then we get your kind of thoughts around topics, possible speakers. If you want to speak, let me know. If there's something really interesting going on in your Cancer Alliance or your kind of area you'd like us to present on, that would be great. Obviously, you're the most knowledgeable about what's happening in your areas. So, and we very much want this to be a national group, and we want to hear from people around the country. So please do suggest topics and speakers as well. Another thing is about days and timing of meeting. So, 1 o'clock on a Tuesday used to be the preferred, but it may be going forward that's less good for people. So there's a range of different options that I've suggested that we'd be able to accommodate in terms of facilitation. And then some feedback on sort of topics we've covered this year in terms of kind of relevance to your practice. It'll just help us kind of gauge where to go with 2026 topics. So yeah, really need your help in kind of shaping what happens next for the group. For one horrible moment, I thought I'd stop the meeting rather than unshared. So brilliant. Okay, so I can't really see many people now, but I can see that it's nearly 2 o'clock. So probably time for us to say goodbye. Wishing people a happy festive period, and we'll see you in 2026 with some dates and hopefully some nice exciting topics to bring to the meetings, and look forward to the sort of future discussions around personalised cancer care. One thing I'm asking you for is a more snazzy title for our meeting, because the National Informal Discussion Group for Personalised Cancer Care does not ever roll off my tongue. So if anybody has some inspiration around that, I'd very much appreciate it. Okay, Lucy, you're having problems getting onto the chat, is that right?
No, I just wondered if we would be able to if there was anything in the chat that might be useful for us, if there were any additional comments, I just wondered if we could be sent them or see them or something. That would be really useful.
Yeah, can you see the chat okay at the moment?
I can, yes.
Okay. Do you mean if anything else comes in and after the meeting's finished? Yeah, sure. I'll send them across to you.
Okay, lovely. Thank you.
Okay, then thanks everyone. See you in 2026. Bye. Okay, bye-bye.
Thanks, Sandra.
Okay, bye-bye. See you soon. Bye.